Ever wonder what's the best thing to tell patients who are trying to get off their sleep meds? What's the most effective way to help them sleep without medication? Hi, this is Brain Bites with me, Dr. B. I'm Jessica Beachkovsky, your friendly online psychiatrist. Today I'm going to share some highlights from an article, and we'll find out some magic stuff you can tell your clients that they can do for their sleep. Let's dig in. This article that I'm reading today is Cognitive Behavioral Therapy for Insomnia and Hypnotic Deprescribing. This is by Joshua Hong-Jin Cho, MD, PhD. From the September 2025 issue of, I think, Psychiatric Times in the psychosomatic section. Everyone watching this video is probably familiar with cognitive behavioral therapy for insomnia, which is first line for treating chronic insomnia, even though I don't specifically teach CBTI. I do share resources with patients, and I do give them some snippets of what they can work on. We don't do the 6 to 8 week manualized treatment, but if they're motivated, I do actually try to get them to do some of the things and give them as homework from our sessions. It's very effective. Patients just don't want to do it. And in fact, in studies, when they do this for clinical trials, the dropout rate is pretty high, anywhere from 10% to 40%. So it's tough. People don't want to do the sleep deprivation piece in the beginning. They don't want to get out of bed. They just want it to work. They just want to sleep already. So I'm going to read through some of the things that I thought were most interesting here. So 70 to 80% of the people that complete a course in CBTI will have a good therapeutic response, and 40% of those people will have clinical remission of their chronic insomnia, which is not usually something we see with medications. It has long-term efficacy, and some studies show up to a year, even though most of these studies don't actually follow patients that long. But there are some persisting benefits past 10 years. That's pretty significant. This is all based on the idea, the 3 Ps, the predisposing, precipitating, and perpetuating factors. So those are the things that contribute to the problems that people have with insomnia. There's the initial vulnerability, like what genetics do you bring, what's unique about you that makes insomnia more likely. Any kind of stressful events, triggers, things that lead to insomnia, especially acute insomnia, and then perpetuating factors, the maladaptive behaviors, the cognitions, all the things that keep people in that loop of not being able to sleep, worrying about being able to go to sleep, worrying about not getting enough sleep. CBTI is based on cognitive restructuring, which is excellent and super important for patients, and it helps them change those sleep-related thoughts. I thought this was interesting, although I talk to my kids about this all the time, and I tell myself this, I don't talk to patients about it, and that's embracing the reality that sleep is out of their control and surrendering to whatever happens regardless. So the control that patients have over their sleep is to remove any kind of impediments to sleep. So taking care of any stimulus, getting out of bed when you're awake, doing all of the things that we know will mean good sleep. They have some studies of tribes of hunter-gatherers, and they only hear a report of about 1% of occasional insomnia, which is excellent. And their average sleep is 6.4 hours. We already know that saying 8 hours for everybody is not the answer. But right now, based on a bunch of longevity studies, it's showing that 7 hours actually might be an even better number than 8, and certainly 9. A sleep duration of 7 hours predicts the lowest all-cause mortality. So that's pretty excellent data right there. One of the things we often see with people that struggle with insomnia is the fact that they feel like other people have amazing sleep all the time, or that their goal for sleep should just be that they can just lay down in bed when they're ready to go to bed at bedtime. They'll fall straight to sleep. They'll sleep solidly for 8 hours, and then they will wake up refreshed in the morning a minute before their alarm goes off. But that's not really how sleep works anyway. Sleep is much more irregular. It is out of our conscious control. The more we want to sleep, the more sleep will elude us. But recognizing that the sleep cycle lasts about 90 minutes, so there's a cyclic nature to your regular natural sleep, healthy sleep, and that you often will wake up 5 times during the night. Every time one of those cycles is done, you will wake up and then go back to sleep. Most people don't remember all of those, if any of those, but this is a natural part of your sleep cycle. So it's not bad and it's not unusual. So we've always heard the thing, the bed is for sleep and sex. There's a lot of activity that happens in a lot of people's beds. A lot of people will watch TV or be on their phones. But the biggest problem with awake bedtime activities is actually just laying awake in bed. Not doing anything, just being in bed and being awake. And then building that association of when I'm in bed, I don't sleep and I'm more anxious. So then having that perpetuated over and over again. And then suddenly now when you get in bed, it's not a safe, relaxing place. It's a stressful place where is tonight going to be a night that I sleep or a night that I don't sleep? So just to use some of the terminology, lying in bed when awake becomes a habit that reduces your sleep drive. And the sleep restriction, which is kind of what this is founded on, is based on getting up at a very specific time, not just waking up, but getting up and getting out of bed at a specific firm get up time, where the goal is to start reducing the amount of time that patients are spending in bed so that their sleep pressure is increased, meaning that when they do finally allow themselves to go to bed and it's time to go to sleep, that they are more likely to fall asleep and less likely to lay there awake because they are really tired. Even though this is a really powerful intervention, getting people to sleep restrict is very challenging. Just some basics, the time in bed is gradually increased, usually by 15 minutes per week. And patients should start to notice deeper and more refreshing sleep as they move through the weeks. Many patients may end up being satisfied with 6.5 hours of sleep, even though their goal may have been 8. But by getting much more restful sleep, they might appreciate the fact that this is good enough and will move forward with that. Plus, that number is magic for longevity, right? 6.5 hours is supposed to be great for reduced mortality. When patients are trying to get off of hypnotic medications, so the sleep medications, this can be very effective. Only about 40% of patients successfully get off their hypnotics without CBTI, but that number rises to 80% when it's used. So one of the recommendations in here was that you can initially decrease the dose of the sleeping medication by 25% per week, and then get down to the smallest dose, and then hang out there for a couple of weeks while you're continuing to do the CBTI. Then you take that same dose every other night for a couple of weeks before then just stopping it. And part of that piece also is to let patients gain confidence. They're taking such a small amount of medication that it doesn't have a big effect on how much sleep they get. They're already doing the CBTI skills and they're already able to fall asleep better and have more restful sleep. So that just improves their confidence in the idea of not needing the medication. So then hopefully they can stop the medication. I don't recommend that you teach patients specifically to do this. Obviously, this is something that they need to talk to their prescriber about, especially in cases of chronic depression or bipolar disorder. If they have a seizure disorder, we need to make sure sleep is managed by a medical professional who's prescribing. But for patients who are motivated, this is a really helpful way to get them off the medication and improve their sleep quality. Considering how short this treatment is and how long the results last, it's surprising that more patients aren't aware of it, but that must mean that their providers are not sharing this information. It is much easier for a doctor to write a prescription every 3 months for a medication forever than it is to walk a patient through the 6 to 8 weeks of what's required for CBTI. There are not enough providers, obviously, out there that are trained in this to teach everybody. There are some good online options. There are some ways that motivated patients can do this for themselves. But ultimately, we're not doing a good job of sharing this with our patients and just talking about the benefits, how great the benefits really are if they can implement it and get past the hard part, the quality of sleep and the improvements over time and the sustained benefits. Money. So I think overall, this article is a great reminder to talk to patients about CBTI as an option for their insomnia. Sure, a medication once in a while is fine. A couple of days of sleep medication here and there, totally fine. But for people who have chronic insomnia, CBTI is first line. And it sounds like it's also excellent for helping people get off their hypnotics so that they can safely and successfully get off their sleep medications and still be able to sleep at night. This has been Brain Bites with me, Dr. B. I hope your brain is full of glorious, restful sleep, just not during my video. Enjoy more tasty tidbits at brainbiteswithdrb.com. Enjoy.